ATCM, the emergency medicine channel.
Yes.
50-year-old female with no comorbidities presented to ER with decreased response for past 2 days associated with multiple episodes of vomiting. Initial 10-second assessment. Airway airway is patent, but with gargling of sounds was present. Mild pooling of secretion was also there, so suction was done initially. Breathing, respiratory rate was 30 per minute. Saturation was 98% in 8-liter O2 in facial mask. Bilateral crepes were there. Circulation wise, pulse rate of 104 per minute with a BP of 120/80 and S1 S2 present. Disability GCS was E1 V1 M1 with the exposure GRBS of 120. Temperature was 100 degree Fahrenheit. We given PCM as well as tepid sponging was given. In view of low GCS and gargling and query aspiration, we intubated the patient and shifted the patient into mechanical ventilation after getting informed consent from the bystanders. So,
low GCS is the indication.
Indication, low GCS and aspiration. Then adjuvants to primary survey, we did an ABG showing a pH of 7.38 with a bicarb of 23. Lactate was 2.6. Potassium, no other electrolyte abnormality was seen in EBG. ECG was showing sinus tachycardia. CBC CRP wise total counts of 16,000 with an HP of 10.6 with a platelet of 280 and a CRP of 70. Like sample history. 50-year-old female with no comorbidities presented to ER with complaints of decreased response for the past 2 days. Patient was apparently asymptomatic 2 days back. Sudden onset of unresponsiveness followed which patient have 2 episodes of vomiting, post which patient was not at all responding to any commands or even pain. Was admitted in outside hospital, was evaluated, only positive, the blood works, everything was within normal limit except for ammonia. Ammonia was in the range of 600. So they came here for further evaluation and neurological assessment. Outside already did an MRI which doesn't show any bleed or stroke, bleed or acute infarct. Patient when came, we after intubating and initial management of the patient, we sent all the routine labs including LFT, RFT, CBC CRP. LFT was within normal limit. RFT was also normal limit. Electrolytes, everything was within normal limits only, sir. But ammonia was high. Our ammonia was also in the 900 ranges. So during assessment in our ER, patient started developing seizure. First we given Midas, but it was an intractable seizure. Even with Midas boluses and Midas infusion, seizure was not subsiding. Along with Midas, we also started other anti-epileptic drugs.
What are the anti-epileptic drugs which can aggravate ammonia, increase the ammonia levels? Sodium valproate. So some of these drugs itself can produce, can increase the ammonia level. So we should be very careful. Okay. Can ammonia increase after seizure?
Yes, after seizure also ammonia was increasing. Increase in trend only. First patient came.
Any patient, if you take ammonia levels after seizure will be increased, but not to this height. This is 900. So mild elevation of ammonia is known after seizures. That is because of the muscle contraction.
So then as the ammonia, so we initial diagnosis of hyperammonemia, query unknown cause of cause haven't been diagnosed yet. So only positive history patient is giving, no comorbid patient only was taking some other alternative medications for generalized weakness for the past 2 days prior to this onset of complaints. Then since hyperammonemia, and it was in thousands range and in increasing trend, we started in more HD. Hemodialysis was done. So
what are the ways you can treat hyperammonemia?
So hyperammonemia can accumulate in our body due to different causes. Most common cause in a young child will be urea cycle deficiency. So in case of any patient with urea cycle defects, we can given sodium benzoate can be given, which act by sodium and benzoate will conjugate with glycine, causing, forms epurate, which is water soluble, can excrete ammonia through our urine. Otherwise, in the excessive amount, only way to remove ammonia is hemodialysis.
Other than like this patient is not very young, he is in old age. Be some other reason might have triggered this hyperammonemia, not genetical disorder. What are the ways you can reduce ammonia in the body? Dialysis is ultimate choice. Other than that,
high protein diet. Reduce protein diet.
Reduce protein diet.
Laxatives.
Which laxative? Lactulose. Lactose. That reduces ammonia. Lactulose. Then look for rifaximin. Reduce the same like how you treat CLD. Okay, but this one will not reduce like that because the problem is something else. It is a production inside the body, not absorption.
So, days of hyperammonemia, it could be a liver disease, CLD, then renal disease, GI bleed, UTA, that is caused by urease positive organism like protease, then urethrosigmoidostomy, post-urethrosigmoidostomy, shock, severe muscle excretion or heavy exercises, cigarette smoking, transient HA in newborns. Then drugs causing hyperammonemia include valproic acid, barbiturates, diuretics, alcohol,
narcotics. Here you are not supposed to use this type of drugs for control of seizures.
Valproate and barbiturates or valproate can't be used in here. Then systemic in post-lung transplant, if there is a mycoplasma infection or ureaplasma infection, that can also cause hyperammonemia.
Mycoplasma infection is known in a normal person. This bilateral pneumonia is in mycoplasma infection. How do you diagnose? How do you treat it? Not very common. We have seen lot of mycoplasma type infections. How do you diagnose? How do you treat it?
Diagnosis is by sputum culture.
Clinically, patient can present with like bilateral pneumonia presentation. Bilateral infiltrations can be associated anemia,
hemolytic
anemia can be present, hyponatremia,
hemolytic anemia, diarrhea. That hemolytic anemia is very atypical serology. Atypical pneumonia serology you have to send. How do you manage it?
Antibiotics.
It's antibiotics.
Azithromycin.
So all these things we have to do because we don't know what is the reason here in this patient.
So we sent all the labs investigation, but everything said to be normal only, and culture was also pending for this patient.
How do you diagnose seizure in this patient?
Seizure.
Are you seeing active seizures?
Active seizures. Active GTCS was there, sir, which was even medication. It was not retractable. Every 2 minutes she was seizing, or 5 to 6 episode in 1 hour was there. And post which we also did the 24 hours EEG, which is also showing generalized tonic activity. So due to hyperammonemia, it could be a cerebral edema which can cause seizure, or brains.
Dialysis is done?
Dialysis done, but patient was not that improving trend.
What else? What else you want to add? I read about this. It's a new topic. It's a difficult case to control seizures. Dialysis, temporarily it will relieve, but we don't know what is the actual reason behind this case. Children, we can advise the diet and lactose, you can control it. Mostly you can control it. But adult, it will be very difficult. Unless until you find out the reason. Whether the drug has caused this change, we don't know.
So Then there is a valproate toxicity that can cause hyperammonemia, sir. So in usually in valproate toxicity, sorry, the plasma ammonia level will be more than 80 microgram per dl. This is due to mostly due to accumulation of propionic acid, which metabolize with VPA, which is a component in urea cycle, which disrupted the urea cycle and causes hyperammonemia. There's
Tell me,
a
what are the dialysible toxins? This is one of the dialysible toxins.
toxins,
Tell
valproate.
what are the other dialysible toxins? Every time discuss in ICU, no? Lystic must,
barbiturate,
barbiturate, lithium,
Lithium.
INH,
High.
S is sodium valproate, T is theophylline. Pinna, what is it? Next thing? C in there. Carbamazepine, I think carbon. S is again streptomycin.
salicylic acid,
Salicylic acid. So these are dialysible toxins that you should remember. Some of the toxins you can dialyze. Okay. So
Case patient.
very difficult case.
Difficult. In this patient mostly after aspiration and multiple
So
seizure.
aspiration, what antibiotic you selected? What are the antibiotics which has got a higher seizure potential? That is a thing you should know.
Ciprofloxacin,
Ciprofloxacin, fluoroquinolones and penicillins, meropenem, that all comes in same group. Okay, so that you should avoid. You can go for other drugs like here, since you are getting bilateral pneumonia, you can go for azithromycin or doxycycline, depending on the severity. If you want to have a higher drug, alternative to penicillins you can select, because most of the penicillins will have some seizure potential. Try to avoid these drugs. Anaerobic coverage has to be there.
We started with subtraction, third generation.
Subtraction, will it has got a seizure potential? In a patient who is having seizure, it can induce sometimes. But we have to try. Ceftriaxone is not a good choice here. You are treating an aspiration pneumonia. You don't need to go for ceftriaxone. You can go for alternative drugs when the patient is having seizure. Not in all patients. Patient who is already having retractable seizure, then better to go for an alternative. Okay.